So it's been a pleasure. It's been a pleasure to be part of this, and thanks again to Stuart and the UK TS for inviting me to do this. So I will move on if I'm able to. Somehow it seems to be frozen, the screen. We don't want a repeat of the last time. So somehow it's not moving, allowing me to move forward. Let me just click on that. There you go. So there's quite a lot to get through this evening. So I will get onto that as soon as. But just to give you an overview again, as before, 3 parts to the presentation. Those are rough times. The first part is a recap of previous sessions because some people may have joined today for the first time, and it's just helpful to give them a little bit of a taster of what we've been covering over the last 3 weeks. So that's part 1. Part 2 will focus on tonight's topic, which is diet and nutrition, major organs and the gastrointestinal tract. And then I like to end off with some tips about lifestyle and empowerment. So we'll end off the session with that this evening. And again, I like to start off with the background of who I am, so people have a sense of who I am, particularly those joining us for the first time this evening. You may hear by the accent that I was born in Cape Town, South Africa, and experienced my own or had my own experiences of racism and marginalization. And that was really key in me now being an advocate for marginalized groups and people that are underserved, which is why when I was asked to do this talk, I was willing to help. I was qualified as a dietitian in South Africa, then moved to the UK in 2000. So I was introduced to sickle cell and thalassemia in 2011, and 2012 worked as a social liaison officer, supporting both sickle cell and thalassemia patients with their social care needs. But it was only in 2014 that I was introduced to nutrition in sickle cell and thalassemia. But during that time, I had always heard nutrition in the context of thal. I'd never heard of nutrition in the context of sickle cell, which is why my doctoral research project focused on sickle cell and not on thalassemia. I had lots of challenges doing that because no one knew a lot. I didn't know a lot, but I managed to successfully complete my doctorate in December 2023. So this slide you will see for the last time is just an overview of what's happened and what's to come. As I said, tonight we'll focus on the major organs, the liver, heart, kidney stones, and lungs for this evening's session. So part 1, as I said, is a recap of the previous sessions, and I'll touch on a little bit about iron overloading because the nutritional problems you will see, you would have heard from the previous presentations, but also from this evening, is almost the underpinning sort of problem that results in the nutritional problems that associated with thalassemia. So I'll touch on that a little bit. Growth failure, endocrine problems, just an overview, bone health and immunity, which was what we did the last session. And then again, I like to end off with a summary of the nutrients for healthy living, because that is the foundation for nutritional choices for healthy living. So I'd like to sort of just give you that foundation again. So starting with the overview of diet and nutrition in thalassemia. And again, for me, it's really important that patients know the clinical features of the condition, in your case, thalassemia. And so for thalassemia, the problem most experienced is ineffective erythropoiesis, and that's just the process of making red blood cells. What you find as well, there's chronic hemolysis, which is the rapid breakdown of your red blood cells, resulting in anemia, oxidative stress, inflammation, and hypercoagulability in terms of clotting, and then also something called extramedullary hematopoiesis. And that hematopoiesis is basically the formation of blood cell components that's outside of the bone marrow, and that can result in some of the deformities that we see in thal patients as well. And we know, because of the regular blood transfusion being the main treatment for thalassemia patients, particularly beta thalassemia major patients, it's the primary iron overloading. And so just to recap again, the main 2 types of thalassemia is beta thalassemia major, also known as transfusion dependent thalassemia, and then also thalassemia intermediate, which is the non-transfusion dependent thalassemia. Coming on to the nutritional implications of this iron overloading that I mentioned earlier, again, a summary, and this is basically what we covered over the last 3 sessions and certainly what we will cover this evening. So we looked at iron and iron overloading in the context of it causing anemia, malnutrition, growth failure, the endocrine problems experienced by patients, in particular pancreatic insufficiency, diabetes, hormonal imbalances, and last 2 weeks ago, we spoke about bone health and immunity and patients having a higher risk for osteoporosis and low bone density. And this evening, as I mentioned before, we will be focusing on the liver, the heart, kidney, and then pulmonary hypertension, and we'll touch on the gastrointestinal problems as well. So overview of iron overloading. So we know that iron overloading results in the buildup of iron in vital organs in the body, such as the liver, the heart, and the endocrine glands. But there can also be side effects of the chelation treatment that's used to reduce the iron overloading. And so that leaves the thalassemia with a wide range of nutritional implications that's related to the condition itself, but also to the treatment options. And so in terms of the nutrition effects of this iron overloading, the cause is multifactorial. It's associated with poor nutrient intake, and for patients, they may experience poor appetite. There may be cultural preferences for patients, decreased nutrient density, gastrointestinal distress, and we will see some of that this evening. There might be increased nutrient requirements. So red cell turnover, that's in relation to this chronic hemolysis or the rapid breakdown of the red blood cells, as I mentioned earlier, but also oxidative stress. And oxidative stress, you will see mentioned later on as well, is that imbalance of harmful substances in the cell that can cause cell and tissue damage or even cell death. And there can also be increased nutrient losses because of that. So touching again, just an overview of growth failure. And again, it's known to be multifactorial. So there's lots of reasons in addition to the iron overloading, and that's related to malnutrition. And specifically the nutrient deficiencies related to the malnutrition. And this results in or results from the severity of the anemia that patients can experience. And the anemia basically dictates to a degree the availability of oxygen to the cells of the body, the tissues, as well as organs. And we will see later on the impact that can have as well. And so this anemia can have an impact on patients' ability to maintain normal growth and normal development, but also affect their energy levels and the ability to, undertake normal activities of daily living. This will have and does have an effect on the quality of life that patients can lead if this isn't treated promptly. So when we think about growth failure in the context of thalassemia, there's a number of nutritional considerations, and there's 3 key areas. And the first thing is that patients are regularly monitored every 6 months in pediatric clinics. And this is to correct the anemia that patients can experience, but also to monitor the iron overload and make adjustments to iron chelation as needed. Again, as mentioned earlier, the calorie or the energy density of the food is really important. So ensuring that the patients get enough and adequate calories, nutrients, proteins, vitamins, and minerals. And we've already seen from the other sessions that we've had that key minerals and vitamins are affected, such as zinc, folic acid, vitamin D, and vitamin A. But also importantly, that patients and families have the right kind of support, ongoing support, such as psychological, social, and emotional support to ensure that they are able to cope and manage the condition to the best of their ability. So thinking about the endocrine problems, which we focused on in session 2, and again, this is as a result of the side effects of the iron overloading and ineffective iron chelation. And the problems patients can experience when they have endocrine problems is pancreatic insufficiency. And the problem with pancreatic insufficiency is that it affects the enzymes that the body can release, the digestive enzymes. So lipase to break down fats or lipids, proteases to break down proteins, and also amylase to break down carbohydrates. So we can see that that can have a nutritional impact on patients. Also, patients have an increased risk for both type 1 and type 2 diabetes, but many patients also have an increased risk of developing diabetes, so pre-diabetes. And some hormonal imbalances, including hypothyroidism and hypogonadism. And what are the nutritional implications of these endocrine problems? So we can see that patients can have malabsorption of nutrients because that enzymes are not there to break down the food or the macronutrients into its, you know, the nutrients that can be absorbed by the body. There's impaired digestion. There's impaired blood glucose control, which we find in particularly type 1, type 2 diabetes. Patients can have abnormal lipids, this dyslipidemia. They can have an increased cardiovascular risk, and we did quite a bit of that session 2 when we spoke at that point. But also there can be the hormonal functioning, which results in the delayed pubertal maturation that patients experience. So I've included prediabetes again because we do have an opportunity to reduce your risk of developing type 1, certainly type 2 diabetes, if we can manage and reduce your risk of prediabetes. So what is prediabetes? It's an intermediate state of glucose control, and that does give you an increased risk of going on to develop diabetes, but we want to prevent that from happening. And so with prediabetes, you have the presence of excess glucose levels that's above normal, but not quite yet diabetes. And patients will have what's known as a GTT, or a glucose tolerance test, to determine whether they have an increased risk for, or whether they have prediabetes. So some of the things that we suggested to prevent the prediabetes going over to diabetes is to follow a healthy lifestyle, follow a healthy diet, to engage with physical activity. And again, we saw last time that we spoke about the importance of physical activity for thalassemia patients, to avoid and stop smoking if you're already smoking, to improve your blood pressure control, and to achieve and maintain a healthy weight if you are at a slightly higher BMI. And also, as I said, to reduce this dyslipidemia, this abnormal fat content of the blood. So this slide, again, I've included it just to give you an indication of the food distribution when you have this increased risk of diabetes. So the recommendation is that if you're thinking about your plates, your dinner plates, that half of it should be from your non-starchy or lower carbohydrate vegetables, as you can see in this image. And then the other half of the plate you would divide into two, the top, the 1/4 to be your starchy carbohydrates, can be potatoes, can be rice, can be pasta, whichever you enjoy, chapati. And then the other 1/4 should be from your proteins, both animal, or if you're vegetarian or plant-based, tofu, whatever you have as your options. But this should be ideally a way that you can reduce the risk of you developing sort of diabetes, because you are managing the carbohydrates that you're taking through your diet. So thinking about hormonal imbalances, again, the two conditions we spoke about was hypothyroidism. And the thing with hypothyroidism we highlighted there was your increased risk of cardiovascular disease, because the hypothyroidism actually results in an increase in blood fats. So cholesterol, which we know is a risk factor for heart disease, LDL or low density lipoprotein, which is known as the bad cholesterol. So that can also increase the cholesterol level and also increase your risk for heart disease, triglycerides, and then lipoprotein A. The other thing that is associated with hypothyroidism is this reduced parathyroid secretion, which results in hypocalcemia, which is low levels of calcium in the blood, and also hypophosphatemia, which is the low levels of phosphate in the blood. And we know that calcium and phosphate is important in the context of bone health. And so the recommendation is that that you choose healthier fats, so going more for mono and polyunsaturated fats, examples here being olive oil, rapeseed oil, and also choosing omega-3 rich foods, which we spoke about before. So your oily fish, your salmons, your mackerels, your sardines, but also plant-based omega-3 rich foods, walnuts, and walnut oil as well, flaxseed, chai, soybean, canola oil are also good examples. And then when you're thinking about hypogonadism, we want to look out for and check and correct these levels of minerals and vitamins that may be low if you are at risk of, or if you are experiencing hypogonadism. So specifically zinc, vitamin D, selenium, and we know because we spoke at the last session that these nutrients, these minerals and vitamins are again important for bone health, but also for immunity. So an overview of bone health, so which is what we did the last time. So we know that patients with thalassemia have an increased risk of low bone mass, and this does increase with age. There's reduced bone formation, but also reduced accrual of the bone mineral that strengthens the bone and reduces your risk for fractures, etc. So when you have established bone disease in the context of your thalassemia, this is an important contributor to morbidity associated with pain for patients, increased risk of fractures, and in some patients they can also experience vertebral collapse. And so we can see those problems associated with bone health can have a role to play in the quality of life for patients with thalassemia, and particularly thinking about vitamin D deficiency. And again, we've spoken, in the context of both bone and also immunity, the vitamin D supplementation is recommended routinely for patients with thalassemia, even patients who live in areas that have really good levels of sunshine. And also to note that vitamin D is important for calcium absorption, but also that iron overload can lead to impaired calcium homeostasis. So vitamin D plays an important role, and the supplementation of it is really important in the context of thalassemia, but also in terms of the bone health. So moving on to the immunity side of things. So in thalassemia major patients, we do find there's an increased risk for patients for serious infections. And this can be systemic infections. So systemic just refers to systems in the body. And this is because there's a defect or defects in the body's defense mechanisms, those things that help fight off infections. There's a defect in those mechanisms. And the main causes for the infections in the context of thalassemia is iron overloading, the chronic immune stimulation, due to repeated blood transfusions. Some patients may have had splenectomies, removal of the spleen, but also the immune deficiency that I've just mentioned for patients. So I've included the image that I had in the last session because it's just a really good sort of picture to demonstrate what healthy bone looks like, but also what unhealthy bone looks like. And you can see in the image on my right-hand side would be your left-hand side. When we have bone disease, how the spaces between in the bone actually become enlarged, and that results in the thinning of the bones and making bones more brittle and more fragile. So for some patients, even sneezing or just knocking themselves can result in fractures. And so it's important that, obviously we pay attention and we take on board the recommendations that were made in terms of the vitamin D we spoke about the last time, the calcium, to reduce the damage that can come from osteoporosis. So just to end of the session, again, just recapping the healthy eating principles. As I said, all of the nutrients that I have mentioned already and that I will mention this evening comes from the Eat Well Guide, which is what the UK government has identified as sort of the basis for healthy eating. And you can see from the image that I have there, using the South Asian Eat Well Guide as the example, is that there's 5 main food groups, and the different colors, the green one being the fruit and vegetables, the yellow being the carbohydrates, the starchy foods, the pink being your protein foods, the blue being your dairy foods, and then the slither is the purple being your fats and oils. And if you're thinking about the carbohydrate foods there, we're thinking about starches, breads, chapati, dosa, thalpa, idli, semolina, potato, cereal. So that group contains all of your carbohydrate containing foods. And then the vegetables and fruits, you can see there's a range of vegetables and fruits there as well. Thinking about proteins, beans, pulses, dal, soya chunks, meat and alternatives, fish, eggs. So all of those foods, it just gives you an indication of the breadth of the food choices from that group. Thinking about dairy, so again, milk alternatives, lassi, cheese, yogurt, and then the fats and oils. But you can see that you only need a small amount of oil, which is why there's only a slither. Because actually, if you think about the energy content from fats and oils, is actually double that of carbohydrates and double that of proteins. But just to finish off with this image, if you see on the outside of the circle, we've got water. So water is important to include in the normal diet, but also reading the food labels. And we spoke a lot about that in our last session, but also highlighting that on the outside of the Eat Well guide, you will see there's things like sugary drinks, there's cakes, there's pastries and pies. And so we're saying that, you know, it's not that you can't have those things, but you have less of them because they're not going to provide the breadth and the range of nutrients that you need to be able to address the key problems that you experience because of iron overloading and thalassaemia. So just going through briefly some of the key functions of those food groups and the foods within those food groups. So carbohydrates, best sources there. It's the best source of energy for the body, for the brain, central nervous system, muscle, and digestion. So we can see all of the systems of the body actually need energy to be able to function optimally. But the choices of the carbohydrates is also important. And so the recommendation is that you go for more unrefined, so whole grains, foods that contains higher fiber content, and also the no added sugar options, and including having your fruits and veg, aiming for your 5 a day. With protein, again, a very important nutrient to maintain good health and vitality, but it's also important for growth and development and repair. And you can see protein is part of all of the tissues, bones, nerves, hair, skin, hormones. And I've highlighted there the protein sparing effect. So if we don't take in enough carbohydrates in our diet, then the body will actually start using protein for energy. So we do want to ensure that we're taking enough carbohydrates, and the protein that the body will use will be from the muscles, that, you know, from our muscles. And so we want to maintain a good muscle mass and therefore ensure that we take enough carbohydrates. So going on to vitamins and minerals, we know now from the sessions that I've covered that you can't get vitamins and minerals. The body doesn't make vitamins and minerals. It does need vitamins and minerals to come from the diet. So we should be taking in a range, a variety of foods that can actually provide the body with the vitamins, because again, you can see there that vitamins are important for growth, for maintenance of health, prevention of disease, and similarly with minerals, very important in terms of a range of biological processes, muscle response, digestion, metabolism, production of hormones. And so we do need to ensure that through the diet, and again, looking at that Eat Well guide that I've just shown you, that's the basis from which you will choose the foods to ensure that you get in the nutrients that you need for good health. I mentioned water. Our body is made up of over 70% of water, so we do need to take in enough water, but we also need to take in enough fiber to keep our digestive system healthy. So I always include this slide about diet and iron overloading, because this is always something that's asked. So in terms of patients with iron overloading, and particularly patients with non-transfusion dependent thalassaemia, the recommendation is that you do limit the amount of iron in your diet, but importantly that you are also compliant with iron chelation regime, because that will definitely help to reduce or not to add to the existing iron that's already building up in the organs that we mentioned already. So what can you include in your diet if you do have iron overloading? So you can have fruits and vegetables. You can have grains and legumes. So thinking again about the Eat Well guide and the different groups that I mentioned, but also lean protein sources like chicken and turkey is allowed. Having tea and coffee with meals is a way to actually reduce iron absorption. And then also having less foods that contains vitamin A and certainly vitamin C, because that can enhance the absorption of iron. Reading your labels, as you can see in that image there again, reading your labels is important. So checking on foods that may be fortified with iron and you know, trying to choose that doesn't have any iron. I know there was a comment from a parent in the other sessions to say that her child enjoys the cereals that are fortified with iron. So it can become a little bit tricky in trying to find options that the kids will enjoy that doesn't contain iron, but it's just having that awareness. And then reducing the supplements if you are having supplements, to reduce iron, supplements that contain iron. So I've whizzed through part one, and hopefully, I mean, this is the last of the 4 sessions. Hopefully by now you'll have a really good sort of understanding and balance and base from which to choose and make really good choices in terms of improving, you know, your nutrition in terms of managing your thalassemia. So we'll move on to part 2, which is the, as I said, the main part of this evening's session, and that is looking at diet and nutrition in major organs and the gastrointestinal tract, and specifically the liver, heart, kidneys, lungs, and we will touch on gastrointestinal problems as well. So starting off with liver-related problems in thalassemia, and I started off the session just to give you an overview of the normal functions of the liver. So the liver is a really important organ. It's critical in terms of supporting metabolism. It's important in terms of immunity, digestion, detoxification, and vitamin storage. And so you can see when you experience problems related to thalassemia because of iron overloading, you know, it can have a host of nutritional problems that needs to be addressed. So the liver is the primary or the main site of iron deposition in all of the iron-loading anemias. The liver cells known as hepatocytes are also the main site of the storage of iron, but it's also the main site of the synthesis of hepcidin, which is a hormone and a key regulator of iron homeostasis. So when the body needs more iron, the hepcidin will, the production will be increased so that the body can absorb more iron. But we know that in iron overloading, you know, that is something that we try to reduce as much as possible. But the liver is also the site for the production of iron storage proteins. However, in patients with transfusion-dependent anemias, the capacity for iron-binding proteins to store iron is overwhelmed because of the continuous sort of buildup of iron in the body. And this allows iron, unbound iron, to accumulate in the hepatocytes or in the liver cells. This triggers oxidative stress, leading to cell death. So this oxidative stress is something I mentioned in the beginning, and that is also in relation to the chronic hemolysis that is a clinical feature for thalassemia. And the problem with that is the cell death. So when the cells of the liver die, that is when we run into problems, and that is when we develop liver disease, and that needs to be reduced as much as possible. And to do that, adequate screening of the liver is of utmost importance, and that is checking for risks in relation to viral hepatitis, but also hepatitis B and hepatitis C, which are blood-borne infections. And this is, you know, in the context of you having your regular blood transfusion. So the risks come from the fact that you have regular blood transfusions, and this needs to be monitored and screened regularly. The main causes of liver damage relates to the inflammation that comes from the oxidative stress. So the inflammation can also be caused by viral hepatitis, but it can also be caused by iron toxicity. And it's this iron toxicity that then leads to the death of the liver cells, which can increase the fibrotic tissue within the liver itself. And this fibrotic tissue can eventually lead to cirrhosis, which is sort of when the cells of the liver die. And this is as a result of the inflammation. So for some patients, in addition to that, they may have something called steatosis, and that's just the chemical name or the medical name for fatty liver, which I will touch on later on in the presentation. This is the build-up of fat in the liver. And this can also increase the risk of fibrosis. And as we can see there, that if a fibrosis is allowed to continue, that can lead to cirrhosis, which is death of the liver cells. We can also have an increased risk of you developing gallstones. And this can also contribute to liver disease. So in the next slide, I give you an overview of the gallstones, because this has actually been identified as one of the most prevalent complications in thalassemia, in particularly in the liver itself. And this comes because of this increased iron deposition within the liver cells, also hemolysis, so that's rapid breakdown of the red blood cells, as well as the ineffective erythropoiesis. So when those processes happen, we find that there's destruction, or the red blood cells are destroyed or broken down, and bilirubin is formed in the liver and also excreted in the bile. So bile is important to help with digestion of particularly fats, in the body, further down in the digestive tract. So what we find, because of this breakdown of those red blood cells and this increased excretion of bilirubin in the liver, there is what's known the development of multiple bilirubin gallstones. So the gallstones that you will experience are actually an accumulation of the bilirubin that comes from the breakdown of those red blood cells. So in non-thal patients, you will find gallstones developing that also contains cholesterol. And we know also in the context of thalassemia that cholesterol can be increased when you have, for argument's sake, or not for argument's sake, when you have hypothyroidism. So you know that that is already a risk factor for patients with thalassemia when they have hypothyroidism. But also bile salts can also accumulate to form gallstones. And when you have these multiple gallstones in the gallbladder, patients can experience a range of symptoms, and for many patients that is pain. And that then results in patients having to have the surgical removal of the gallbladder called cholecystectomy. But there are other causes of gallstones for patients, and that is when patients lose weight very quickly. That can also result in patients developing gallstones. So it is a very common problem, and it's important to understand, how the gallstones are formed, because that will give us an indication of what we can do in terms of in terms of how we manage it nutritionally. In the case of thalassemia, the gallstones come from this ongoing process of the rapid breakdown of red blood cells. And so we do need to work with patients to see how best we can manage it in terms of nutrition. So further risks in terms of the liver and liver-related problems. So as I mentioned earlier before, that it's important that the risk factors are identified as early as possible. And during that process, patients need to be offered preventative interventions to try and reduce their risk of liver damage, also the progression of the liver disease, worsening iron overload, and also increased risk of viral hepatitis. So timely identification is highly advocated. Also, the ongoing regular monitoring for early detection of risk factors is therefore essential for patients. And what has been reported is that there are potential for patients with liver disease to progress to hepatocellular carcinoma. So this is something to consider as well. And so I would highly recommend that you attend and have your risks for liver disease monitored regularly and as soon as possible. So some of the recommendations for the prevention and management of liver disease, some general advice is adequate iron chelation. To ensure that you have your hepatitis B vaccinations Again, when you're having your regular blood transfusion, for the safety practices to be associated with that. But if you do already have liver disease, to avoid the consumption of alcohol. Why? Because the liver actually breaks down alcohol. And when that happens, it actually also causes the death of the liver cells. So if you already have impaired or liver disease and you're having alcohol on top of that, that can just worsen the symptoms and almost speed up the progression of your liver disease. So you want to avoid alcohol consumption by all means. So coming back to thinking about recommendations, but in the terms of general dietary factors, what is really important is thinking about the energy balance. So ensuring that there is a balance between the energy that you take in, particularly energy from fat, to ensure that you don't have what's called this increase of fat in cells other than the liver cells. With the imbalance of energy intake, this can have an effect on the liver disease, particularly because when you take in too much fat, that can actually lead to fatty liver. And there's a slide on that, so we'll talk a little bit more on that topic when we come to that slide. In addition to this, patients can have an increased risk for micro and macronutrients. So micro being your vitamins and minerals, macronutrients being for protein and fats as well. In addition to that, patients can have an increased risk of fat-soluble vitamins. Patients may be susceptible to protein deficiency, and we know that protein is an important nutrient that's important for growth and development, but also an important component of so many parts of the body, tissues, cells, hair, etc. So we want to reduce that risk of protein deficiency. Patients with cirrhosis may have a higher risk of micronutrient deficiency. There can also be a decrease of storage of vitamins, fat-soluble vitamins like vitamin K, but also there's a reduction of vitamin D in some patients, and this can be due to destructive hepatic disease. So you can see that there is a role to play in terms of trying to limit the progression of liver disease and ensuring that when you are thinking about nutrition, that you are paying attention to the balance of the energy, particularly the fat that you take in, so that you can reduce some of the risk factors associated with liver disease. We stuck again? So coming back to the fatty liver disease, as I mentioned, and it's commonly known as non-alcoholic fatty liver disease. This is known as a global health problem, and iron is a leading cause of liver damage, in particularly transfusion-dependent thalassemic patients. But there is a lack of data on the correlation between non-alcoholic fatty liver disease and liver damage in transfusion-dependent thalassemic patients. But there was one study conducted by someone called Paddy Nia et al. 2022, and this was conducted in patients with non-transfusion-dependent thalassemia. And these patients had steatosis, which is that fatty liver, the buildup of fat in the liver. But in these patients, they were associated with an increasing BMI. So they had a higher BMI to normal. And it's this combination of having fatty liver and having a higher BMI that actually increased the risk of liver fibrosis. So for patients with transfusion-dependent thalassemia, those with a higher BMI will have a high, and fatty liver will have a higher risk of developing liver fibrosis. So we do need to ensure that we try and get patients with a higher BMI to within a more normal BMI or body mass index. So for this reason, there is a recommendation that all patients with liver pathology or damage to the liver, they are required to have a full nutritional status assessment. They are offered individualized advice, but also that they that if they do need supplements, that is provided to patients. I've added in on this slide nutritional assessment. So from a dietetic perspective, there's a number of things that we would look at in a patient if we are undertaking a nutritional assessment for patients. So some of the things that we would look at, and you can see there, it's the ABCDE acronym. So A being anthropometry. And so anthropometry relates to the body composition. It relates to your BMI, your body mass index, which is the ratio of your weight in relation to your height. Biochemistry is the blood results. So we would look at your bloods. We would look at your clinical factors. We would look at your risks for the condition, in this case, liver disease. We would look at dietary factors. You know, what are you choosing? What are your choices? What are your meal patterns? But also consider environmental factors. And we'd also look at patient-specific factors. And so when you look at nutritional assessment, it's important that you do a full assessment that covers all these important facets for patients. So that is the liver-related problems. So now we're moving on to the heart-related problems in thalassemia. And cardiac disease, like liver, is a major concern in thalassemia. And this is in relation to iron chelation, because the iron chelation decreases early deaths from cardiac failure. So when a patient with thalassemia complies and they have really good iron chelation, this can actually reduce their risk of cardiac failure. However, we know that patients with thalassemia may have an increased risk of atherosclerosis because of the increase, particularly if they have hypothyroidism, they can have this increase of fats, cholesterol, triglycerides, low density lipoprotein that can increase your risk of heart disease. So patients with atherosclerosis, this process can be sped up in the presence of inflammation that is due to iron overload. So again, it's important that we try and reduce the risk for patients, you know, of developing atherosclerosis. So some common problems in thalassemia in terms of the heart, atrial fibrillation or AF, and this is actually known as the most common arrhythmia in thalassemia. So a third of patients are known to have AF. And the most common cause for this is iron overload, but also the harmful effects of increased oxidative stress. And we've mentioned that before. And so, again, important to note that AF can actually be reversed. Iron-induced AF can be reduced or reversed by intensive iron chelation regimen. So compliance with your iron chelation is important. So continuing with heart-related problems in thalassemia, so thinking about heart failure, and this is the end result of conditions severely affecting the heart structure, but also how well the heart is able to function. And amongst the main cause of death, it is one of the main cause of death in the context of thalassemia, and in particularly those patients with an suboptimal blood transfusion, and also those who are not sort of fully compliant with iron chelation. So again, that is really important to reduce the risk of heart failure. So what are some of the recommendations then to try and reduce heart failure? The continual restriction of salt. So this you would obviously have your medical team providing you with recommendations around how much salt and reducing the amount of salt intake. Abstinence of alcohol, and we've already seen in the case of liver to reduce and avoid alcohol, so the reducing, staying away from alcohol, following a good general healthy diet, following a healthy lifestyle, stopping smoking, because smoking can damage the heart and blood vessels, but also engaging in regular exercise. But this needs to be tailored to the patient's health status. So as we spoke before the last session, that doing some sort of exercise slowly and gradually building up would be the best way to do it. So if you've never done exercise, you know, you want to be doing it slowly. But in the case of heart failure, that engaging in regular exercise tailored to your health is important. So the next couple of slides will touch on a number of nutritional factors that can affect heart complications. And again, a key number of nutrients we will look at. So we'll start with vitamin D deficiency. So vitamin D deficiency is associated with cardiac function and also cardiac iron loading. And we know already that for thalassemia, that vitamin D supplementation is suggested to maintain normal serum levels. And this is to promote cardiac health, but also to prevent osteoporosis, which we said before, and to prevent hypercalciuria, which is the calcium in the urine, increased amounts of calcium in the urine. So if you're moving on to zinc deficiency, so again, zinc deficiency is known to, it may affect the heart and the vessels. Also, it's affected by the modulation of oxidative stress, which we've already mentioned. It's also associated with heart disease in the general population, but there's limited evidence in the context of thalassemia. So in thalassemia, zinc deficiency is associated with impaired glucose metabolism, and we mentioned this in session 2 when we spoke about type 2 diabetes. And this in turn, if you do have diabetes and you have impaired glucose control, that can increase your risk for heart disease. So the recommendation and suggestion is there as well that you maintain a good blood pressure control, and that can also help to improve your risk for developing heart disease. So thinking about zinc supplementation, again, it's suggested in thalassemia patients with diabetes or those with impaired glucose metabolism. So nutritional factors, moving on, thinking about selenium deficiency. This is not associated with coronary artery disease. However, selenium supplementation has shown improvements in the markers of inflammation, and we know that iron overload can increase inflammation, but by patients having selenium supplementation, that can reduce the markers of inflammation, and also oxidative stress in patients with coronary artery disease. So there's almost an inverse sort of a positive effect of, of selenium on the heart. So in terms of iron overloading, we now know that iron is deposited in the heart. And this is because of repeated blood transfusions and increased intestinal iron absorption. And this results in major complications in thalassemia patients in relation to cardiac dysfunction, as well as heart failure, as we mentioned before. So when it comes to the management of iron overloading in the context of heart disease or heart problems, the recommendation is for patients with non-transfusion dependent thalassemia to, as I mentioned before, to restrict iron overload, to restrict iron in their diet, to reduce the iron overload, and also to maintain a low iron diet. But it was interesting that for patients with transfusion-dependent thalassemia, that was highlighted that the impact, when you compare the impact of iron overload that comes from regular transfusions to the iron overload that can come from nutritional absorption, the impact is quite low. And so the recommendation there is strongly the adherence to optimal iron chelation, to try and reduce the effect of the iron overloading. So that's the end of looking at the cardiac problems or the heart problems in thalassemia. So we're moving on to a big word, nephrolithiasis, which is the chemical or the medical term for kidney stones. So the next couple of slides will focus on specifically kidney stones as a problem in thalassemia. It is identified as an age-related condition. It's in relation to it being more common because people have a longer life expectancy. People are, because of medical improvements in medical management, people are living longer. But the incidence of kidney stones in the general population has been identified to be 9%. But when we look at the thalassemia population, that number is double and more. You can see there 18 to 59%, but it's more common in adults with thalassemia. However, the precise prevalence and age is not known for the onset. So kidney stones result from something called biomineralization, which is when living organisms produce minerals. And there's a couple of triggers for stone formation, and this is related to changes in the saturation, the solubility, the hydrodynamics, or the imbalance between stone promoting and inhibiting components. And just to let you know, for further information, the composition of stones, it is identified to be quite a highly complex process. There's an ordered matrix. It contains proteins, trace minerals, metals, organic acids, lipids, polysaccharides, but most stones are calcium-based. So the risk factors, and again, there's limited information known about the risk factors in thalassemia, and most of the guidelines have come from the general guidelines that's used for the general population because of that. It's known that 50% of stones in the general population are due to genetic factors, but there are behavioral, environmental, metabolic, and disease-associated factors, and we will go through those in a bit more detail in a couple of slides to come. So nutritional risk factors. So a diet that can help to reduce stone formation. Again, we're looking at the general population because there isn't enough information on guidelines in the thalassemia population at the moment. So in terms of the general population, a diet rich in vegetables, low in protein, has been known to reduce the risk of stone formation. Also a high intake of citrate, which is a salt, phytate, which we find in plants, that has also been shown to actually inhibit stone formation in the urine. And these salts and phytate, they actually compete for binding of calcium and other minerals. So when we're looking at the diet that increases the risk of stone formation, so this is in relation to having a diet that's actually rich in animal protein. And what this does is it increases the presence of calcium in the urine, uric acid in the urine as well as oxalates in the urine. Also the reduction of citrate excretion. But when you follow a diet that's high in fructose, so fructose we get from the sugar that's found in fruits, but also from honey. So a diet that's high in fructose, a diet that's high in salt has also been identified with an increased risk of stone formation. So therefore, the recommendation is that you take in moderate amounts of calcium, protein, and a low salt diet. And this has been shown to help reduce the recurrence of kidney stones in the general population. So some other nutrients in the context of risk factors for kidney stones. So thinking about calcium. So calcium, supplemental calcium, so taking a supplement, a calcium supplement, has been associated with an increased risk of stones, but not when you take calcium through the diet. This has actually been associated with a reduction in the risk of the incidence of kidney stones. We also know that there is a reduced intake of calcium in patients with thalassemia, and because many patients have lactose intolerance, there might be personal choice for people not taking calcium-rich foods. There might be cultural beliefs where patients don't take calcium-rich foods. So in thalassemia patients, we also know that you have an increased risk of or a reduction in bone mineral density. We spoke about osteoporosis because of which increases the risk of osteoporosis. And so for many patients with thalassemia with a decreased bone mineral density, you will most likely be on some sort of calcium supplement that's often prescribed. So it's just bearing in mind that when you are taking calcium in the form of a supplement, that potentially that may have an increased risk of you developing kidney stones. Vitamin D supplementation, however, is not associated with an increased risk of stone formation. But again, more research is needed in the context of thalassemia. Vitamin C, however, higher doses, that's more than 1,000 milligrams, has been associated with an increased risk of stone formation, and this was in healthy men. But thinking about thalassemia, we know that vitamin C may be deficient because of the iron overloading and its impact on antioxidants. And so, again, in a thalassemia context, moderate doses are recommended, but to avoid doses that contains higher than 1,000 milligrams, because that may potentially increase your risk of developing kidney stones. For zinc, both in the general population both high and low intake of zinc is associated with an increased risk for stone formation. So thinking about hydration or, fluid intake, in general, there's a need for an increase in fluids to help reduce stone formation, and this will help to dilute the stone forming minerals. When we think about thalassemia patients and tea consumption is associated with 10% fewer stones. And remember when I had the slide up about patients following a low iron diet and having tea with your meals, that has an impact to reduce iron absorption. So tea consumption in thalassemia patients also has shown as I said, a reduction in stones. But the added bonus in thalassemia is that it helps to reduce iron absorption from non-heme iron. Obesity in the general population has also shown some sort of increased risk of patients developing kidney stones. So patients with a higher BMI may have a higher risk for developing kidney stones. We know that patients with thalassemia on the whole will have a normal BMI, but sometimes patients may have a higher fat content for their body weight, and this potentially may increase the risk of kidney stones. So again, as we spoke about in the liver, we do want to ensure that you maintain a more normal BMI, so weight in relation to your height. So some of the other risk factors, as I mentioned, that was identified in the general population, so environmental factors, so ensuring that you're taking enough fluid. So if you're in environments that are, there's extreme temperatures, you may not take in enough fluid, and this can actually concentrate the urine. So you want to ensure that you take in enough fluid, because that can increase your risk of stone formation. So by increasing your fluid intake, that can have a positive effect on the metabolic. Hypercalciuria, which is the increased calcium in the urine, but also reduce the presence of uric acid in the urine, as well as, I've repeated myself there, uric acid in the blood and also uric acid in the urine. Other risk factors, disease-related, so splenectomies, patients with increased erythropoiesis, iron overload, chelation therapy, and iron-associated complications that can have a risk factor in regards to you developing kidney stones. When you have hypoparathyroidism, because there's low parathyroid hormone, and that reduces calcium reabsorption. Patients with diabetes, so in the general population, it's been identified that's actually an independent risk factor for developing kidney stones, and also patients with high bone turnover. So that concludes the slides on the kidney stones in thalassemia. So we'll move on to pulmonary hypertension in thalassemia. So pulmonary arterial hypertension is, again, age-related. It's an age-related complication in thalassemia. It mostly affects patients with non-transfusion dependent thalassemia. Patients with beta thalassemia major is less frequently affected. It's associated with right-sided heart failure, and this affects the quality of life of patients. it affects your exercise tolerance, but also carries a risk for mortality for some patients. So what are the key risk factors for patients with pulmonary hypertension? So chronic anemia, ineffective erythropoiesis, hemolysis, iron overload. So we know that these are key clinical features of thalassemia and in the context of iron overload. Vasculopathy, patients with splenectomies, hypercoagulability, and also echocardiographs are used to diagnose patients with pulmonary hypertension. So what to highlight from the slide is that it's important that you do that you do comply with your iron chelation to help reduce the impact of the clinical features associated with thalassemia. So what are the recommendations following a low salt diet? So recommendation is 2,000 milligrams of salt a day, 2 grams a day. By reducing, help to manage fluid retention, reducing the risk of edema. And also the Pulmonary Hypertension Society has suggested that you limit the intake of fluid to 2 liters per day. And that will have an effect or help to reduce as well, as I said, the edema and that fluid retention that can be associated with pulmonary edema. Sorry, with pulmonary hypertension. So we're coming close to the end. So gastrointestinal problems. So actually, when I looked at the recommendations in terms of gastrointestinal problems in thalassemia, there wasn't much that I could find that's specific in terms of thalassemia. So I thought the next 2 slides, basically, I highlighted acid reflux and how it's managed in the general population, just to give you an overview of some of the risk factors, but also some guidance that you can use to try and reduce the effects and the impact if you are currently suffering from acid reflux. So what is acid reflux? It's actually when the stomach acid travels back up towards the throat, and that's that burning sensation or that heartburn sensation that you can experience in your chest area, but also can leave an unpleasant sour taste in your mouth. And this can occur, or the symptoms are worsened after eating for patient, or when they're lying down, or when they're bending over. So what are some of the causes? And I want you to pay attention to some of the causes. And again, as I said, this is in the context of the general population. So certain foods and drinks, particularly coffee, tomatoes, alcohol, chocolate, fatty or spicy foods, and you may recognize that some of these foods for you can be triggers. Being overweight, if you smoke, that can increase your risk of acid reflux. If you are stressed and experience high levels of anxiety, that can also increase your risk of acid reflux. Some medications can increase acid reflux for pregnancy in some patients, but also stomach ulcers. So how do we ease heartburn? So some of the do's and the don'ts, again, in the context of general population, but I think may be helpful if you are experiencing problems with acid reflux. So some of the do's is eating smaller frequent meals. So if the acid reflux is associated with you eating, then having smaller meals more often, that may have a positive impact in reducing your symptoms and experience of acid reflux. Trying to lose weight if you are overweight, and also trying to find ways to relax if your acid reflux is associated with anxiety. That may be a helpful thing. If we move on to the don'ts. So avoiding dietary trigger foods. So that means you have to pay attention to what are the main triggers that may set off or initiate your experience of heartburn. And it may be that when you drink coffee, that may trigger heartburn. It may be when you're having a fatty meal, or when you're having spicy foods, or when you're having chocolate. So pay attention to what are some of the main triggers for you in terms of the diet, and trying to avoid having those foods to reduce your risk of experiencing symptoms of heartburn. Avoid eating 3 to 4 hours before you go to bed. So that may help to reduce, because again, you will have an empty stomach, and that may sort of definitely have a positive impact in the food or the acid sort of traveling up into your esophagus when you lie down. Wearing loose clothing around the waist, because again, if you have something tight, that can also add that pressure and increase the acid moving up into sort of either your throat, and you're experiencing the symptoms of heartburn. Avoid smoking. We've heard that countless times. So if you are smoking, stop smoking, and yeah, just completely avoid smoking by all means, because we've already seen what effect it can have on your heart as well as your liver health. Don't drink too much alcohol. We've already seen, alcohol, it'll be best for you to avoid alcohol because of the effect it can have on risk, in terms of your liver and also in terms of your heart. So definitely trying to avoid alcohol if you can. I've added on this slide also to check with your medical team or your pharmacist for alternative preparations, because I know that some of the medications, specifically omeprazole was mentioned, can interfere with the absorption or how well your ion chelation works. So it's important to speak to your medical team and also to the pharmacist to maybe see if there's alternatives that you can choose, or maybe if you can alter the timing of taking your preparations and see if that will have a positive effect, in terms of reducing that interaction in terms of your ion chelation. So that's something to just bear in mind if you haven't already done that. But also to bear in mind that antacids, which is sort of one of the common treatments for acid reflux, may not be suitable for everybody. And I've listed the patients with liver disease, and we've already seen the risk for patients with thalassaemia of developing liver disease, patients with kidney disease, patients with heart failure and cirrhosis. So it may be that, in your case, antacids may not be suitable for you to have. And again, it's important to work with your medical team and also with your pharmacist to ensure that you're not taking in any medication that can increase your risk, but also trying to find alternatives that will work for you. So that concludes the main part of the talk on diet and nutrition in terms of the major organs and also gastrointestinal. And so we'll end off this last session, part 3, as usual, with lifestyle and empowerment tips. And I've added this slide just to highlight again and in summary as well of all that you've heard over the last 4 sessions and what you've heard in this evening session. So following a healthy diet, but in particular choosing healthier fats, I wanted to highlight there because we've seen the risks to patients in terms of the increased risk of heart disease, increased risk of the fats that can result in you having an increased risk of heart disease. So we want to ensure that we follow a healthy diet as much as possible. We want to engage in regular exercise and activity. And you've seen in the last session, but also in today's session, that activity is really important, engaging in real activity, but that in relation to your health status is the most sensible approach to that. Sleep, I haven't mentioned sleep before, but a good sleep routine. And we've just seen in the slides before, some patients may experience anxiety, and that, can affect your sleep routine. So it's important that you consider, your sleep routine, how well do you sleep, and ensure that you have a relaxing sleeping area, but also that you have opportunity where you can relax. So think about activities that you can do. It may be that you go for a walk. It may be that you engage in a book. It may be that you meet up with a friend, but ensure that you build in time for regular relaxation and important building in enough time for you to have good sleep. So things not to do, and we've said this over and over again: don't smoke. If you are smoking at the moment, stop smoking. Avoid alcohol. We've seen that alcohol can have an impact on your liver disease if you already have liver disease, but it can also affect your heart. Avoid caffeine or exercise before sleeping. We know that caffeine, particularly coffee, can be a trigger for some patients with heartburn. So we want to ensure, again, that we reduce all those potential triggers that can have a negative effect on your health, your overall health. Avoid screen time during the hour before you sleep. So many of us, we're on our phones and we're reading things. And so in terms of sleep, and we said that sleep is important and building a good and healthy sleep routine. So ensure that you don't, you're not on your phone, the hour before you go to sleep. So these are simple things that you can start incorporating into your pattern, into your lifestyle. I've included this slide. This is a slide that we had in the last session, and just to remind you that for non-THAL patients, the benefits of physical activity is weight maintenance, improved balance, improved bone and heart health, improved glucose tolerance, and reduced anxiety and stress. But in the context of physical activity in THAL patients, we see that there's improved quality of life. There may be a reduction in your experience of pain. There may be a reduction in serum ferritin levels. There may also be a positive impact on your bone density and the strength of your bone to reduce your risk of developing osteoporosis, but also if you already have osteoporosis, to reduce your risk of fractures. So there's a positive effect to increasing physical activity when you do have thalassemia. We also know that patients with thalassemia may experience pain. The anemia might be a reason why you may not engage in regular activity. Feelings of fatigue and deconditioning may be reasons why you don't engage in physical activity. But also you may have decreased exercise capacity because you've just not either felt that you could engage in activity. But we see that there are positive, potential positive effects for you to engage in physical activity. And so I want to encourage you to consider, if you're not already doing physical activity, and this may be that you do, as I said before, chair-based activity. It may be that you walk around the block. It may be that you do some light activities around the house, and gradually build up. But it's important that you consider and think about what you can do to be more active, and increase your physical activity so that you can benefit from some of the things that we've said can be positive in terms of your quality of life. And so just, in conclusion, then, some of the other things that I have mentioned from session 1, and I will say it again, taking daily positive action is so important. You're living with a condition that, is there, you live with it every day. So you have to find ways to improve and manage that, and to improve your overall quality of life and improve your overall health and well-being. And this is a daily thing. It is a decision that you have to take on a daily basis. And so I want to encourage you to think about what you can do on a daily basis to improve your overall quality of life. Be proactive, be proactive in terms of your self-care. And as someone mentioned before, self-compassion, be kind to yourself. You're living with a really devastating long-term condition, chronic long-term condition. And so, it is important that you be kind to yourself. There will be days potentially where you don't feel like doing anything because you're fatigued or you're in pain. But that's why it's important to build, I would say, a pattern that you can, so on your good days, that you can do things that can really add to and improve your overall quality of life. I have been asking people to think about setting one goal. So many of you, in previous sessions have said that you've considered taking one goal. And one of the goals many people said is around changing their eating habits, because they realized they were choosing foods that were not supporting or improving their health and well-being. So what is one goal that even from today's session that you want to consider doing to try and take positive steps to improving your quality of life, to improving your health and well-being? Again, living with a chronic long-term condition, it's important to maintain and build good relationships. We saw, when we spoke about the growth failure and ensuring that patients have adequate support, patients themselves, but also families have adequate support in terms of psychological, in terms of social, and in terms of emotional support. So ensuring that you have good relationships and good support around you to encourage and because it is something that you will live with for the rest of your life. And so to end of this slide, it's important to remember to ask for help and to ask for what you need. Sometimes we reach a point where we just live and contend with where we are, and we fail to use the resources, the helpful resources around us. So do ask for help from your clinical team and from the medical team that you have, and hopefully together you'll be able to manage your condition in a more positive way, and that will have a positive impact on your overall quality of life. And so one takeaway from this evening session, it's important that, you think about obviously what you've heard this evening. There was a lot of information. Every week, every session has been a lot of information. So take some time to reflect after this evening's session, but also just even if just one thing that you've heard tonight that's made an impression, something that you may have heard for the first time, or something that you may have heard before, but you haven't really paid attention, that you haven't really, put into action. So what is one thing that you can take away from this evening session that you can build in and incorporate into your daily lifestyle, as I said, to improve your overall health and well-being? Thank you. That concludes the presentation and brings us to the end of the session. It's been wonderful. As I said in the beginning, I've learned loads about thalassemia and really enjoyed, spending time with you guys. Hopefully this evening would have added to your knowledge, or maybe be a refresher for those of you who have been doing self-research. But I want to thank particularly Stuart from the Red Cell Network, and also UK Thalassemia Society, Romain, for entrusting me with this time. And I hope that this has been a beneficial investment of your time. Thank you.
Right, thank you very much.
I'll stop sharing.
Again, I'll stop the recording as well. But again, I'll just reiterate, and I'm sure I speak on behalf of the patients on the call as well, your thanks for taking this on. We know, obviously, from your introductions at the start that this wasn't your area of expertise. So